Metabolic obesity, a new therapeutic target for cardiometabolic risk reduction. The last couple of years has witnessed a sea change in metabolic obesity, both in terms of enhanced understanding and in the availability of a panoply of new therapeutic options like endoscopic bariatric procedures, oral semaglutide, and fecal microbiota implantation. And all of us know the global prevalence of obesity has nearly tripled since 1975 and continues to grow at an exponential rate. Cardiometabolic diseases are rocking the entire universe and creating an ever increasing burden on the healthcare systems, both in terms of morbidity and mortality. Although cardiometabolic diseases encompasses panoply of diseases, it is obesity, diabetes, hypertension, and ASCVD which forms the major chunk of cardiometabolic diseases. Distressingly enough, most of these diseases commonly coexist and produces multiple comorbidities which are beyond the reach of a physician or a single specialist to comprehensively evaluate and treat them. Therefore, there is an urgent necessity to build up this new subspecialty of cardiometabolic medicine to tackle the sufferings of the afflicted population. These are some of the diseases which are associated with metabolic obesity: diabetes mellitus, cardiovascular disease, metabolic syndrome, chronic kidney disease, dyslipidemia, hypertension, NAFLD, OSA, osteoarthritis, depression, and so on. What is very distressing is that if you are obese, you have a 30% higher medical cost than those with a normal BMI. How do we measure the cardiovascular risks? This can be measured in a very simplistic way by measuring the waistline and the body mass index. Now, these are the figures for the Indian context. As you can see here, in the Indian context, the normal waistline has to be less than 90 centimeters in males and less than 80 centimeters in females, and the BMI for the Indians is 18 to 22.9 kg per square meter. Now, if an individual has a normal waistline and a normal BMI, the cardiometabolic risk is least. But even with a normal waistline, if he is overweight or he is obese, the cardiometabolic risk increases. On the other hand, if to begin with the waistline is increased, then he has increased risk even with a normal BMI, and as the BMI increases, the risk becomes progressively higher. These are the figures for the Western population or for the WHO. In the West, the normal waistline is less than 40 inches or 100 centimeters, and for females, it is less than 35 inches or 89 centimeters. And the normal BMI for the Western population is less than 25, overweight 25 to 29.9, and obese more than 30. Obesity class 1, 30 to 34.9, class 2, 35 to 39.9, and class 3, greater than 40 kg. Now this shows what is the exact procedure for measuring the waistline. Locate the upper hip bone and top of the right iliac crest. Place the measuring tape in the horizontal plane around the abdomen and at iliac crest. Ensure tape is snug but does not compress the skin. The tape should be parallel to the floor and record measurement at the end of a normal expiration. Now, Indians somehow have more visceral fat, and this is beautifully illustrated in this slide. As you can see, this is past President ADA and this is Dr. Yajnik. Both have a BMI of 22.3, but look at the body fat. Only 9.1% in the past President ADA and 21.2% in Dr. Yajnik. So we also call Indian as thin fat Indians, and this is also nomenclated as non-obese metabolic syndrome. What is the criteria for excess intra-abdominal obesity or visceral obesity? If the excess visceral fat is more than 130 square centimeter, this is visceral obesity. As you can see on the slide, on the left side, the visceral fat area is 146, the subcutaneous fat area is 115, and therefore this is a patient with visceral obesity. On the other hand, on the right side of this slide, you have a subcutaneous adiposity. The visceral fat is normal, 60 centimeters square, while the subcutaneous fat is 190 centimeters square. The pathogenesis of metabolic obesity basically revolves around consumption of high energy foods, physical inactivity, genetic predisposition, and gut microbiota also plays an important role. Currently, there is a tendency to upsize the food. So in the Indian context, we have Maharaja Mac, Jumbo Vada Pav, double cheese pizza, when we need to minimize and not maximize. The children are also getting affected by obesity, as you can see in this slide. And TV cola culture is also rampant in India. People continue to see TV for hours. They consume drinks and eat high energy foods rather than going to fountain or other places where physical exertion is required. This is a gross example of physical inactivity. The individual is taking the doggy for a ride, but himself is in a vehicle, and this individual is sitting on a chair taking drinks. The doggy is doing the treadmill test. Now, if you have a metabolic obesity, as you can see in this slide, these fat cells, adipocytes, in the intra-abdominal fat behave as a very active endocrine organ, and they secrete a panoply of hormones which results in high triglycerides, high blood pressure, insulin resistance, elevated blood glucose, inflammatory markers, low HDL cholesterol, and high LDL cholesterol. Metabolic obesity is a driver of cardiovascular disease, as you can see here, and it is also a driver for type 2 diabetes, which also results in cardiovascular disease. Now, if you have an intra-abdominal obesity, this results in increased insulin resistance and increased cardiovascular risk. The adipocytes secrete a lot of metabolically active substance called adipokines. The PI1 is increased, the adiponectin is decreased, IL-6 is increased, TNF-alpha is increased, and all these results in increased inflammation and insulin resistance. There's also increased hepatic free fatty acid flux, decreased suppression of lipolysis by insulin, increased fatty acids, and ultimately dyslipidemia and insulin resistance, which increases pathogenicity. So that if you have an intra-abdominal obesity, this is associated with increased inflammatory markers, increased free fatty acid, increased secretion of adipokinins, which lead to dyslipidemia, insulin resistance and inflammation, and ultimately increased cardiovascular risk and cardiovascular disease. Now, high waist circumference is also associated with multiple cardiovascular risk factors. You can see low HDL, high TG, high fasting plasma glucose, high BP, and you can have conglomeration of these risk factors. Now, if you have a metabolic syndrome, even without diabetes, you can see the CHD mortality is increased. The green one is the normal without metabolic syndrome or diabetes. The blue one is metabolic syndrome without diabetes. The CVD mortality is also increased compared to a normal individual, and the total mortality is also increased. But if you have a metabolic syndrome with diabetes also, the CHD mortality is increased further, the CVD mortality is increased further, and the total mortality is also increased. And this shows that if you have a metabolic syndrome, the mortality, the CV mortality is increased 5 times or even more. Now, this is a long-term follow-up of patients of metabolic syndrome, and as you can see, the coronary heart disease mortality is increased, the cardiovascular heart disease mortality increased, and the all-cause mortality is also increased. So what are the therapeutics of obesity? The therapeutics basically revolve around lifestyle modification, drugs, endoscopic bariatric procedures, baritic surgery, and fecal microbiota transplantation. Now, lifestyle modification basically involves weight reduction and include a combination of caloric restriction, increased physical activity, and behavioral modification. In the context of diets, a 500 kcal restriction daily equates to weight reduction of 1 pound per week. Diets restricted in carbohydrate typically provide a rapid initial weight loss, and adherence to diet is more important than which diet is chosen. A high quality diet that is enriched in fruits, vegetables, whole grains, lean poultry, and fish should be encouraged to provide the maximum overall health benefit. These are the foods we should avoid. Physical activity, 60 to 90 minutes of daily physical activity, at least 30 minutes. The exercise should be gradually increased, and adherence is important. Some high risk patients should undergo a formal cardiovascular evaluation before initiating an exercise program, and physical activity could be in the form of an exercise such as jogging, swimming, or tennis, or routine activities such as gardening, walking, or house cleaning. In very simplistic term for the layman, lifestyle modification basically involves eat less, eat right, eat in time, walk more, sleep well, and smile. We have a panoply of drugs for decreasing weight, but as you can see, the decrease in weight is to the tune of 6 to 8% or so, except semaglutide, where the weight is reduced to 12% or so. But compliance with drugs is usually a problem in the long run. This is the orally set studies, Endos, which shows a reduction in the body weight and a 45% reduction in IGT patients and 37% in all patients. Endoscopic bariatric procedures. Baritic surgery, no doubt, is the most successful treatment of obesity, has been there for the last 40 years, but many patients avoid surgery due to its perceived invasive nature and fear of complications. Endoscopic bariatric procedures have come in a big way, and they have recently emerged as a safe and effective, minimally invasive procedure for treatment of obesity. They offer effective weight loss at a low cost, and this intervention is gaining greater patient acceptance. Endoscopic bariatric procedures, they also bridge the gap between medical therapy and surgical management, and they may be utilized as a primary procedure, which means patient want to lose some kilos weight, he can undergo an endoscopic bariatric procedure. They can be used as a bridging procedure, which means patient is a candidate for bariatric surgery, but he does not want to get bariatric surgery straight off, so he first undergoes an endoscopic bariatric procedures, and after a lapse of time he can undergo bariatric surgery if required. And they can also be used for revisional procedure, that is, if following a bariatric surgery there's increase in weight, these procedures can be done. These are the different modalities of endoscopic treatment of obesity. We have restrictive procedures, which include intragastric balloons. Then we have tissue apposition techniques, that is endoscopic sleeve gastroplasty. And we also have nutrient diverting therapies like endobarrier, magnetic anastomosis, and mucosal resurfacing. Now these are the panoply of balloons which are available. Intragastric balloons were first approved in the United States in 1985, and we have two types of balloons, the fluid-filled balloon and the gas-filled balloons. The fluid-filled balloons are more effective but produce a lot of nausea, vomiting, and epigastric pain for the first 2 to 3 days. The gas-filled balloons are less effective and produces less nausea, vomiting, and epigastric pain. This is the Orbera balloon, which is a fluid-filled balloon. Reshape is also a fluid-filled balloon, and the Obalon is a gas-filled balloon. Now this is the data on the Orbera balloon and the data from Daya, BK, and Jenke et al. You can see 400 to 700 ml saline can be injected into the balloon. The total weight loss is somewhere around 10 to 15%, and as already said, nausea, vomiting can occur with these others. It's more common with these patients. Initially, the balloons were used for only 6 months, but now we have newer balloons which can be used even for 12 months. This is the data on Orbera balloon, again from the same authors, and you can see you can inject 400 to 700 ml saline, and the weight loss is again to the tune of 10 to 15%, and again the same side effects. Now, Obalon balloon is a soluble balloon, and this is getting more and more popular because the patient is just to swallow the balloon, a wire is connected to the balloon, and you can fill the balloon with air or nitrogen. So the procedure of a soluble balloon is very simple. It can be utilized as an OPD procedure, and the weight loss is around about 7 to 10 or 12% at the end of 4 weeks. Now these are the side effects associated with. You can have pain, nausea, GERD and erosion in some percentage of patients. The total weight loss with balloons is around about 8%. This is data from the Indian context. Diabetes is resolved in 50% of cases and hypertension in 90% of patients. The late complications include GERD in 10%, again data from the Indian context, and gastric ulcers in 20%. Now this is the endoscopic sleeve gastroplasty, which is getting very popular, and these are the 3 endoscopic instruments which are used to produce endoscopic gastroplasty. The LGP restored suturing system, the overswitch for endoscopic sleeve gastroplasty, and the incision-less operating platform for primary obesity surgery. This is the restored suturing system, and this is the Apollo overswitch, which is also commonly used. And with this you can take full thickness sutures of the stomach and create a gastroplasty. Now this is the post-op picture of a gastroplasty. You can see the stomach is reduced to a sleeve, its volume is greatly decreased. And this is the effect of the gastric retention. You can see gastric retention even at 240 minutes 3 months after endoscopic procedure, which means this is very effective. And the learning curve, again data from the Indian context, the first 30 cases 74 minutes and the next 71 cases 52 minutes. Again data from the Indian context, diabetes was resolved with endoscopic gastroplasty 76%, hypertension 91% and OSA almost 100%. This is again Indian data from the endoscopic sleeve gastroplasty. You can see patients which are included had BMI 34%. The mean duration of procedure was around about 68 minutes, and the average total weight loss at the end of 1 year was about 90 or 20%, which is quite good. The endoscopic sleeve gastroplasty trial has also achieved the primary endpoint, and it will be presented in future, and you can see the proportion of patients who attain greater than 10% total body weight loss and 25% effective weight loss at the end of the 3 months post-ECHG, 62% in 70%, and at 6 months post-ESG, 81% and 86.5%. What about the endoscopic malabsorptive procedures? We have the endo barrier. It basically involves placing an impermeable barrier between the food and the absorptive mucosa within the foregut. And this is the mucosal resurfacing. The duodenal mucosal resurfacing is a single minimally invasive endoscopic procedure that involves circumferential hypothermal ablation of the duodenal mucosa, resulting in subsequent regeneration of the mucosa. Before ablating, the mucosa is lifted with saline to protect the outer layers of the duodenum. And this is the magnet anastomosis, which is also sometimes used. What about bariatric surgery? Bariatric surgery is the most effective way to lose weight. It has been there for the last 40 years. Bariatric surgery enhances weight loss in obese people who have not achieved long-term success with other weight loss attempts. Basically, there are 3 types of bariatric surgery. This is the Ronex gastric bypass. In this small gastric pouch with bypass of the small intestine. The duodenal switch, partial gastrectomy with anastomosis of the stomach to the distal ileum, that is biliopancreatic diversion, and this is the adjustable gastric vending. The first 2 procedures are restrictive plus malabsorptive, while the gastric vending is only restrictive. Now this is a comparison of the 3 types of bariatric surgery. Ronex Y gastric bypass, this is the most common form of bariatric surgery in the United States. It is less malabsorptive than the duodenal switch, and there is improvement in the cardiometabolic risk factors. But it is more invasive than gastric vending. Malabsorption may lead to vitamin deficiency and higher risk of complications than gastric banding. Duodenal switch is the highest rate of weight loss, improvement in the comorbidities, and greatest risk of vitamin deficiency and greatest risk of complication. But gastric banding, there's only a small risk of complication, is least invasive procedure, but the efficacy is also lesser compared to the first two procedures. Now these are the facts about weight loss surgery or bariatric surgery. Obesity, all of us know, produces 3 to 10 years of weight loss, loss in life expectancy, and the bariatric surgery produces 40 to 45% reduction in heart complication for patients with diabetes and obesity. The benefits of sustained weight loss through bariatric surgery include long-term revision for type 2 diabetes, improved cardiovascular health, relief of depression, eliminate obstructive sleep apnea, joint pain relief, improve fertility, and alleviate several other medical conditions. Whatever is the procedure performed, you can see the benefit is always there. You can see this is before surgery, this is after surgery, before surgery, after surgery, and again before and before after surgery. This is sleeve gastroplasty. This is a lady, poorly controlled diabetes with insulin and hypertension. Euglycemia is achieved in 2 weeks. This is an individual diabetes, 7 years, in hypertension and obesity, immediate diabetes resolution. And this is sleeve gastroplasty, again in this girl, hyperinsulinemia, impaired GTT, strong family history of diabetes, following surgery. Besides weight loss, post-surgery, GTT is normal. Then we have the Robiotic bariatric surgery, and the most recent innovation in bariatric surgery is the introduction of the robots. Robotic surgery for obesity has definite advantages over conventional laparoscopic surgery due to its 3D vision and precise innovative multi-range instrument that add more safety to the patient, but it's very expensive and the learning curve is long. So in summary, metabolic obesity is reaching alarming and epidemic proportions, and these are the therapeutic approaches which you can see on the slide. The effect of endoscopic bariatric treatment for weight loss is greater than that of drugs, but lower than that of bariatric surgery. But endoscopic bariatric procedures have fewer complications and bariatric surgery, and they are being increasingly preferred by the patients. Fecal microbiota implantation is still in the process of evolution. So the shape of the things we are witnessing is shown in the upper part of the slide, and our desire is to reverse the change, as you can see in the lower half of the slide. The message for the lay pupil amidst the pandemic of metabolic obesity is that you can follow this simple movement of 80s if you want to live for 80 years. Waist 80 centimeters, blood sugar 80, diastolic blood pressure 80, LDL cholesterol 80, walk at least 80 minutes in 3 days, alcohol not more than 80 ml in 3 days, 80 meters away from smokers and do not smoke, smile at least 80 times in a month, have relationship with your spouse at least 80 times in a year, and give 80 minutes to yourself every day. Thank you very much for your kind attention.